Welcome to today's video. It's entitled God's Battle Plan for Osteoporosis. So it's about faith, wisdom, and wellness in action. Just little steps that will make you cope better with any osteoporotic conditions. So this video is the fourth in a series of God's Battle Plan. Okay, we had done battle plan against cardiovascular, cancer, diabetes, and now today is osteoporosis. Osteoporosis is a condition of decreased bone density. Okay, osteo means bone, porosis means pores. Okay, porous bone means, look, this is normal bone, and osteoporosis, the bones are more porous, there's more holes, okay, there's more pores. As a result, this makes the bone more fragile and the risk of fractures significantly increases. Okay, osteoporosis, women over the age of 40, especially menopausal women, are more prone to osteoporosis because estrogen helps the bone retains the calcium. But when you enter menopause or entering menopause, the estrogen level decreases and a woman will be more prone to this disease. Men can also have osteoporosis, but only a few. But the main reason is that men have higher bone density to begin with. Osteoporosis, which develops with aging in both men and women, is associated with decreased, basically, physical activity. Okay, our bone is constantly being remodeled. It's constantly being broken down at the same time being formed. Right? We are a living organism. Our bone is an organic tissue. It's not an inorganic tissue like a piece of plastic. Right? So this is a picture of a femur, the hip bone. See, you got the cortical bone, right? Or the compact bone, which is for the strength, for the weight bearing. So when you have weight bearing, so the compact bone will take the hit, right? And then inside the bone, there's a spongy bone, where you've got like holes, porous. So with osteoporosis, what happens is that there's more and more pores, the bone becomes more brittle and you're more prone to fractures. So, the cells that breaks down the bone or bone resorption, okay, is called osteoclast. So when you break down the bone, then you release calcium to your blood. But meantime, your bone is also being formed by a cell called osteoblast, right? So there you go, bone remodeling. You see the scale, right? So when bone resorption is more, then what happens, right? You break down bone more than you form bone. And if it's the other way around, if bone formation is more, then you got strong bones. You got a strong bone mass, right? When you're young, because of hormones like estrogen, testosterone, HGH, and physical activity, you form very good bone mass. Typically, bone mass is maximized at when you're about age 30, 29, 30, 31. So it's very important when you're young to do physical activity, weight-bearing exercise to maximize your bone mass. Once in your 30s, then to maintain it, so to sort of limit the decline, right? But you want to start off with a high level of bone mass, okay, before the decline starts. Because bone mass is important for bone strength. So bone formation decreases with age, with decreased physical activity, and when our hormones are depleting due to age, menopause, andropause. For bone resorption, we can use drugs like bisphosphonates to slow down that bone resorption. Biblical foundation for osteoporosis, right? My bones are not hidden from you, or my frame is not hidden from you. So God knows everything about your body. Our bodies are the temple of the Holy Spirit. And so He cares for our well-being, our health, and our wellness. So integrating faith science is something we need to do for many of diseases, right? Because God created us, And God also created doctors like myself. He also provides wisdom through medical knowledge. Doctors are created by God. Supplements and lifestyle changes are tools of healing. And faith empowers perseverance in any treatment. Okay, the effect of osteoporosis is more on the spongy, in medical we call it the trabecular bone, more than the cortical bone. And it can lead to certain conditions. One is a dowager's hump, kyphosis. You are like, like those old ladies, right? Where they're like hunched, right? Because why? The vertebrae has collapsed. The thoracic vertebrae has collapsed. It can lead to hip fractures, right? Because your hip is called a femoral neck is fractured. Or Colles fracture. When you slip, you fall down, right? Your wrist gets fractured, and you get what I call a Colles fracture. Many people don't know they have osteoporosis until they actually break a bone. However, with the help of advanced bone scanning equipment, we can check our own bone density, and osteoporosis can be diagnosed and treated early to stop its further deterioration. Good living habits can also help prevent this disease. Here you go, kyphosis, the Dowager's hump, right? With fractures of the vertebrae just collapse until you get kyphosis, or Dowager's hump. Hip fracture, as the bone gets brittle, then you bleed, and this can be deadly, because you can lose a lot of blood from a hip fracture, and often happens in elderly women after a slight fall, a slip. So what are the risk factors for osteoporosis? Okay, unmodifiable risk factors include, female, more risk, premature menopause, late menarche, that means late onset of periods. Because why? Because your exposure to estrogen in your blood is shortened. Right? Remember, estrogen is protective against osteoporosis. Nulliparity, that means you've never had a pregnancy before. Short stature, slender build. If you are Asian, you're more at risk, okay, versus a Caucasian. Family history of osteoporosis, fair skin, especially Chinese ladies, right? Okay, modifiable risk factors include smoking, physical inactivity, low dietary calcium, alcoholic abuse, caffeine abuse, or estrogen withdrawal. So as far as the risk factors are concerned, there's interplay of yourself, the host, female, age, your age, whether you're postmenopausal, smokers, sedentary, childbearing status, versus aging, what you take, ingestion of calcium, low estrogen, increased testosterone, then environmental like stress, okay, and then the lifestyle that you lead. Bone examination. So if you think you are at risk of developing osteoporosis, you should visit your doctor to discuss your concerns. Your doctor may order blood tests and check the calcium level in your blood and your thyroid level. It's better to check it early before just getting a fracture, like hip fracture. So they can do an X-ray. They can do your bone densitometer for your bone density. There are other tests which quantitative computerized tomography for your trabecular bone, single photon absorptiometry with radioactive iodine-25, especially for bone where surrounding tissue is thin, like the humerus. These are not necessary, but most of us just do a simple DEXA scan, dual photon absorptiometry with gallium-153, best for bone where surrounding tissue is thick, like the vertebrae, and a dual energy X-ray absorptiometry. Bone mineral content, your calcium and your phosphorus levels. Bone mineral density, total body mineral density, total body bone mass. These are really way off, but it's just to know that what some reaches, to the research level, what they can test. Markers for blood and urine, osteocalcin, secreted by the osteocyte, the one that breaks down bone, right? So to measure, is it overactive or is it not so active? Your calcium and phosphorus levels in the blood, the alkaline phosphatase enzyme, which, hydroxyproline, amino acid from connective tissue in the bone. So if your hydroxyproline is high, obviously you're breaking down bone, resorbing bone higher than normal. Again, measuring bone mineral mass, okay, absorptiometry, single photon. There are various ways, the ultrasound, you can speed of sound, broadband ultrasound attenuation, skin thickness, blah, blah, blah. So what are some biochemical markers of bone turnover? Okay, you won't normally do all of these tests in a clinical setting, but more maybe research related. Markers of bone formation: serum alkaline phosphatase, okay, serum osteocalcin, okay, serum procollagen 1 carboxy terminal extension peptide. All these you normally won't measure, but it's good to know. Okay, we can measure it. Markers of bone resorption, the breakdown of bone: serum tartrate resistant acid, phosphate, urinary calcium, urinary total, and dialysable hydroxyproline, blah, blah, blah. I won't go too much into detail. Treatment for osteoporosis: besides calcium supplementation, estrogen therapy or hormone replacement therapy is something we used to do years earlier. It still has a place. I remember when I graduated from medical school 30 years ago, I put my mum on it, and she was just going through menopause, and it really benefited her as she gave her strong bones. Estrogen therapy can prevent and treat osteoporosis. After menopause, the ovary stops producing estrogen, a hormone originally used to manage menstruation and preserve bone mass, the bone density, to preserve it. Estrogen supplementation in the first few days of menopause can significantly reduce the risk of developing osteoporosis. While preventing and treating osteoporosis, it also increases the bone density of the hip and the spine, increases your bone density. However, estrogen therapy carries a risk of breast cancer, so when choosing this treatment, you must discuss it with your doctor and needs to be monitored. And probably just, no more than 5 years, right? So other therapies I will go in depth later, includes bisphosphonates, such as Fosamax, selective estrogen receptor modulator, such as Evista, monoclonal antibodies, and parathyroid hormone analogs. Researchers found that bone loss occurred the most bone loss during 1 year before and 2 years after a woman's last period, okay, the perimenopausal period. These 3 years are an important window of time for bone protection you need to take advantage of. So you don't wait until your 60s and so forth, because you've lost too much bone mass, right? So a year before your last period and a few years after your last period is the golden period that you can prevent your bone loss. Okay, talk about other types of medication for osteoporosis besides HRT is bisphosphonates, okay? Like after my mom went off HRT, I put her on Fosamax on and off. I think it's like 2-3 years on and then 1-2 years off, okay? It inhibits the action of osteoclast. Osteoclast is the Pac-Man that breaks down the bones. It inhibits that, okay? So that the osteoblast can build more bone that's broken down. So more bone formation than bone breaking down, because you inhibit the Pac-Man. Selective estrogen receptor modulator like Vista, Loxapine, it mimics the natural effects of estrogen, gradually reversing the breakdown of bone that occurs at menopause. It's just selective, so it will have less side effects like breast cancer, okay, less incidence of breast cancer. Monoclonal antibodies, Eternity and Prolia, which is denosumab, which I'll go into detail later, reduces the formation and action of osteoclasts. Reduces the action of the Pac-Man. And parathyroid hormone. Basically, here's our thyroid. Behind are the 4 parathyroid glands, which regulates calcium metabolism. So how it works in preventing osteoporosis is it increases the number and activity of bone-building osteoblasts. Okay. Talk about menopause. On average, women lose up to 10%. Most reports say 10%. Some even say up to 20% of their bone mass in the first 5 years after menopause. After this, the rate of bone loss slows down. But So the golden period is a year before your last period, a year, I mean, this is your last period, a year before, and a few years after your last period is the golden period where you must try to uh, minimize this bone loss, okay? About 1 in 2 women over the age of 60 will experience at least one fracture due to osteoporosis. I mean, these are some of the commonly available medication from the pharmacies: Fosamax, calcium, HRT, estrogen therapy, Vista, Vistaserm. The rest are all like you need to be administered by doctors. Okay, the newer drugs, the monoclonal antibodies. Okay, bone mineral dense mass in 3 years crossover study. Okay, this is a patient. You see the bone density, bone mineral mass. See, when you take estrogen and progesterone, this one it goes up, up, up. But when you switch it back to placebo, the bone density goes down. Or if you start the patient on placebo, that means sugar tablet, all right, and you switch it to estrogen therapy, the bone density goes up. Whereas you continue the sugar tablet, the bone density continue to decline. Okay, in the early 2000s, okay, there was a big women health initiative study, WHI study, like hundreds, thousands of patients, I can't remember, that were put on the estrogen and progesterone if they still had the intact womb. If they've had a hysterectomy, obviously they don't need the progesterone, they were just given the estrogen. So this was thousands and thousands of women. And the study was meant to be like 5 years, but after 3.5 years, they stopped the study. Why? They found that those women, out of 10,000 women, there was 8 extra cases of breast cancer, right? In the women given estrogen and progesterone. There was 7 more cases of coronary heart disease, 8 extra cases of stroke. There was 18 cases of venous thromboembolism. That means clots in your calf, right? So that's why they stopped it after 3.5 years rather than the 5 years that it was scheduled for. But obviously, it prevented fractures in the hip, 5 lower hip fractures, and all fractures, there was 47 less fractures out of 10,000 women years, right? And in the estrogen-only arm, there was no difference in breast cancer. So after that, people stopped prescribing routinely HRT for menopause women because of the increase in breast cancer. But there's also a question to say that does HRT cause breast cancer, or does it just cause existing breast cancer to grow faster? So that could be the case, right? So a lot of people stop prescribing HRT routinely, but I still believe there's a role for hormone replacement therapy. And even the author of the report says, I think, okay, it is the Harvard professor John Manson, chief of preventive medicine at Brigham and Women's Hospital at Boston and lead author of that study, WHI. I think it's going too far for the study to be interpreted as saying hormone replacement has absolutely no role in clinical practice any longer. Nothing about this hormone study should preclude women who needs hormones to take hormones unless you are at very high risk. Okay, so if you're very high risk, if you've got family history of breast cancer, or you already have breast cancer, or you have high risk of venous thromboembolism, then maybe you're not a candidate for HRT. Okay, and if you were to take HRT, it's on an individual basis, right? Consult your doctor, and you don't have to take it for too long, maybe 3 to 5 years. That golden period where your bone density drops, bone mass drops. And these days, those days, those studies, they were using synthetic hormones, right? I mean, synthesized in the lab, or Premarin is from the horse urine, right? Mostly synthetic. But these days, we have bioidentical hormones from plants, right? They're natural, from plants, from soy or from yam. Bioidentical hormones, particularly when using micronized progesterone and transdermal estradiol. So we can use a patch, right? Or if you have vaginal dryness, you can use a vaginal cream, estrogen cream, vaginal estrogen cream, are generally thought to carry lower breast cancer and cardiovascular risk compared to synthetic hormone replacement therapy. Okay, you can visit specialized doctors who specialize in prescribing bioidentical hormones. Okay, bioidentical HRT, lower risk of breast cancer, potentially lower cardiovascular risk, okay, actually compared to the synthetic and conjugated estrogens and synthetic progestins. Patient satisfaction higher, supposedly. Registration approval, they are FDA approved. There are various, depend on which country. But however, the long-term data is very limited. They don't have big studies like the WHI. It's just small little studies, small data. They don't have a big data like they did with the WHI study. So when I graduated, I just put my mom on it. Okay, didn't study the risk factors or clots, but she was turned out okay. But these days, treatment on HRT should be personalized. Okay, your doctor will also be considering your medical history, any pre-existing conditions like breast cancer, blood clots, or cardiovascular disease, and they might be weighing those risk factors against the benefits of HRT. Okay, benefits of course is prevention of osteoporosis and fractures and colorectal. So you've going through menopause, you should find a doctor that specializes in menopause, and HRT, etc., and treating osteoporosis. So you discuss your symptoms with your doctor, and they will give a review of your medical history, whether you had breast cancer, other cancers, blood clots, whether you have any cardiovascular disease. Then it will talk about the risk and benefits of HRT. The risk obviously is breast cancer, cardiovascular disease, blood clots. Benefits is, of course, osteoporosis prevention, fracture prevention. Then we can talk about the different forms of HRT. It can be systemic. It can be systemic. Then you got the bioidentical hormones, bioidentical, made from soy or yam, or you got the synthetic ones or conjugated estrogens, right, from the horse urine or synthetic progestins. And you can have transdermal patch, less risk of breast cancer. You can have vaginal cream for your vaginal dryness. Then, if you're on HRT, you need to be monitored to make sure that no cancers are developing in your breast. Then you continue to monitor your bone density. And if HRT is not an option, right, there are other ways, other treatments that we just mentioned earlier about treating osteoporosis. And we can go into all these new treatments now. Okay, newer anti-osteoporotic drugs includes anti-resorptive, those that prevent the osteoclast from, working. Bisphosphonates, as I mentioned, is not new, it's quite old already. 幾十年咗, 20, 30 over years, like Fosamax. And then mono-anticlonal antibodies, not long, quite new. Denosumab, we'll talk about it later. And anabolic agents, that means those that build bones, like teriparatide, is a parathyroid hormone analog. Okay, the newer class of drugs for treating osteoporosis are two mono antibodies. Is it a game changer? Well, let time decide. They seem to be better than even bisphosphonates. It is a humanized monoclonal antibody that can bind to and inhibit sclerostin, a protein that inhibits bone growth. So in the bone, there's a protein called sclerostin that prevents bone growth, bone formation, right? So this mono antibody will inhibit this sclerostin protein, then it allows bone to grow. By blocking sclerostin, it kicks bone formation into high gear and simultaneously reduce bone resorption, improving the bone structure.
Hey everyone,
strength.
Welcome back to the channel, where we break down the latest in medicine into clear, powerful takeaways you can actually understand and use. Before we begin, this video is for education and inspiration only. It's not medical advice. So be sure to talk to your healthcare provider and double check with trusted sources. Today we're diving into a hot topic in the world of bone health, Evenity, or romosozumab. Evenity is a monoclonal antibody that builds bone and slows down bone breakdown. That's right, it's a dual-action medication. Most osteoporosis treatments do one or the other. But Evenity, it does both. Let's talk science briefly. Evenity works by blocking sclerostin, a protein that tells your body to stop building bone. When you block sclerostin, your body goes, hey, let's build more bone. It also slows down how fast it breaks down old bone. This is game-changing, especially for patients with severe osteoporosis or multiple fractures. Evenity is FDA approved for postmenopausal women with a high risk of fracture. That includes patients who've already had fractures, or for whom other osteoporosis meds didn't work or weren't tolerated. Here's the kicker. Evenity is not for long-term use. You get 1 dose per month for 12 months only. After that, you switch to another bone-preserving drug to maintain your gains. It's a monthly injection, actually 2 injections, given back-to-back in the doctor's office. Super convenient. No daily pills, no weekly tablets. In clinical trials like FRAME and ARCH, Evenity showed impressive results. It increased bone mineral density in the spine by over 13% in just a year. And it lowered the risk of new vertebral fractures by up to 73% in some cases. Now let's talk side effects. The most common ones, joint pain, headache, and injection site reactions. But here's the big one. Evenity has a black box warning for heart attack, stroke, and cardiovascular death. So, if you've had a recent heart attack or stroke, this medication might not be for you. Your provider will weigh the benefits and risks very carefully. What happens after the 12 doses? You don't just walk away. You'll typically switch to a maintenance medication like alendronate or Prolia to lock in the gains you made. Otherwise, you risk losing that newly built bone. How does Evenity stack up against other meds? Compared to bisphosphonates like Fosamax, Evenity builds bone faster and more effectively in the first year. Compared to Prolia, Evenity builds more bone initially, but Prolia might be better for long-term use. Compared to Forteo or Tymlos, Evenity improves spine and hip density more and only requires monthly dosing. Cost-wise, it's not cheap, but many insurance plans cover it if you meet the criteria. Prior authorization is usually needed, but your rheumatologist or endocrinologist can help with that. If you or someone you love is struggling with osteoporosis, has already had a fracture, or isn't responding to other meds, Evenity might be worth asking your doctor about. It's not for everyone, but for the right patient, it can be a
Okay, cut short. The other monoclonal antibody for osteoporosis is called denosumab. It works by targeting the receptor activator, RANKL, NFKB ligand, leading to reduced bone resorption. That means it reduced the bone breakdown. But this problem with this medication, I can talk about the good thing first. Compared to bisphosphonate maybe you take for 2-3 years, then the bone density will go up and then it plateaus. But this one, even the year 6, year 7, year 8 year, if you take it for 8-9 years, it will still increase your bone density, it will still keep going up. But the problem is that when you stop, there's a rebound effect. The osteoclast will go overdrive and break down the bone very fast, leading to fractures and so forth. So you need to take some bisphosphonates once you stop this denosumab.
Denosumab is a lab-created monoclonal antibody which targets RANK ligand and is a relatively new therapy in the anti-osteoporosis arsenal. RANK ligand is a signaling molecule that is secreted by osteoblasts. So RANK ligand acts on pre-osteoclasts, and here I've used macrophages to illustrate, making them group together to form one giant multi-nucleated bone-dissolving osteoclast. The denosumab antibodies bind to rank ligand and stop them from triggering the pre-osteoclasts, and this way inhibits the formation of osteoclasts. It is given as a subcut injection once every 6 months, and similar to bisphosphonates, can be given for 5 to 6 years. It is a potent anti-resorptive, and studies have shown that it increases bone mineral density across different sites more than bisphosphonates. Another advantage denosumab has over bisphosphonates is in chronic kidney disease, as unlike bisphosphonates, denosumab is not cleared renally, so can be used in stage 4 and 5 CKD. With regards to adverse effects, there seems to be conflicting information as to whether the incidence of atypical fracture and osteonecrosis of the jaw, ONJ, is any better than bisphosphonates or not. Some say yes, and some say it's about the same. It's probably a bit too early to say either way for now. Here is a chart showing collated data from 3 landmark studies, that is Freedom, Flex, and Horizon, which marks bone mineral density change over 10 years for denosumab, zoledronic acid, and alendronic acid. And here it indicates that whilst bone mineral density increases for the first 3 years or so for the bisphosphonates, afterwards there isn't much further increase. Instead, there is a leveling out effect. However, in contrast, the bone mineral density continues to increase year after year for denosumab. So it's not really clear why denosumab is able to do this but not bisphosphonates. So whilst increasing bone mineral density is generally equated with reduced fracture risk, and it is compelling to think that this is not necessarily always the case, and reduction of fracture risk should be assessed separately for completeness. So whilst the increased bone mineral density gains achieved with denosumab seems great, however, there is a very important caution with denosumab, which is that once you stop administering it or miss a dose, there is a profound rebound effect phenomenon where there is accelerated loss of bone density and a rapid return to baseline, plus the occurrence of multiple vertebral fractures is high. And then on top of that, the rebound effect seems to be more profound the longer a patient is on denosumab. In this case study, a female patient in her mid-60s was on denosumab for 9 years. And only within 6 months of stopping, she suffered multiple vertebral fractures. And within 2 years, her BMD levels were back to baseline. But I do also want to point out that in this same chart, it does show that whilst she was on denosumab, her BMD levels did indeed continue to increase right up until she stopped it. It was just that these effects pretty much vanished as soon as denosumab was stopped. In addition, on stopping denosumab, an increase in levels of bone resorption markers is observed, suggesting that stopping denosumab causes a hyperresorptive state. So actually, return to bone mineral density baseline is seen in other anti-osteoporosis medications, for example, teriparatide and romosozumab, but they don't cause this hyperresorptive state with rebound vertebral fractures. So it is not completely clear why the hyperresorptive state happens. It is speculated that it may be due to an accumulation of pre-osteoclasts during the denosumab treatments, and then when denosumab is stopped, they all become activated, causing a hyperresorptive state. So this theory may also explain why the rebound effect is more pronounced the longer the patient is on denosumab. Rapid return to BMD baseline does not occur with bisphosphonates because they are absorbed into the bone. Their anti-resorptive effects persists for months after they are discontinued. The rebound effect can be counteracted by switching to a bisphosphonate on the discontinuation of denosumab, and the bisphosphonate requirement treatment is mandatory. Not only does the bisphosphonate prevent the rebound fractures, it also helps maintain some of the BMD gains, at least in part, so that it doesn't drop back as quickly. With regards to which bisphosphonate to use, for patients who have been on denosumab for several years, zoledronic acid would be a better option because the rebound effects are more profound then. But for patients who have been on denosumab for shorter periods of time, for example, just 1 year, then alendronic acid would be reasonable. Denosumab is not first line, primarily because of the cost. It is reserved for patients with severe osteoporosis who need their bone mineral density to be quickly boosted, or for patients where bisphosphonates have not been successful, and can be a good option or alternative as long as it's understood that therapy cannot be stopped, or if it is stopped, then not without switching to a bisphosphonate plus close monitoring of bone mineral density and bone turnover markers thereafter. And one more thing to note is that denosumab is more effective on treatment-naive patients. So prior bisphosphonate use does blunt the effect of denosumab, but bone mineral density gains are still better in patients who have made the switch from bisphosphonates to denosumab than those who remained on bisphosphonates. And in any case, most patients are started on bisphosphonates to begin with, as that is standard first-line osteoporosis therapy. So to recap, denosumab is a monoclonal antibody which inhibits rank ligand, and thus osteoclasts and bone resorption, so is classed as an anti-resorptive. It is a second-line alternative option to bisphosphonates for patients who are either not able to have bisphosphonates or where bisphosphonates have not been effective enough for them. It is given 6 monthly as a subcutaneous injection, where it does give greater bone mineral density gains than bisphosphonates, although more data is required to determine fracture risk reduction and adverse effect incidence, including atypical fracture and osteonecrosis of the jaw. On stopping denosumab, there is a rapid return to baseline bone mineral density and a rebound phenomenon where there is hyperresorption.
Okay, now we look at the paratype, the parathyroid hormone analog. Here's our thyroid. Behind we got 4 parathyroids that's responsible for calcium metabolism. And how this works is that it stimulates.
What is teriparatide?
Teriparatide is an analog of parathyroid hormone.
Before studying the pharmacological effects of teriparatide, let's review the physiological actions of PTH.
When the calcium concentration in the blood becomes low, the parathyroid glands secrete parathyroid hormone. PTH works to increase the calcium concentration in the blood.
Can you list 3 specific methods?
PTH dissolves bone, promotes calcium reabsorption in the kidneys, and activates vitamin D in the kidneys to enhance calcium absorption from the intestines.
Wait, PTH dissolves bone? Doesn't teriparatide, a PTH preparation, break down bones and worsen osteoporosis?
Good observation. That's the key point. The important thing is the method of administration, intermittently, meaning with intervals. When the PTH analog teriparatide activates osteoclasts and bone resorption occurs, osteoblasts become activated to repair the bone. By giving osteoblasts enough time to repair the bone condition improves. A part of PTH, teriparatide, with a weaker effect than PTH, induces bone resorption by osteoclasts, thereby increasing the activity of osteoblasts. By allowing sufficient time, osteoblasts have enough time to regenerate bone. In this way, bone repair by osteoblasts surpasses bone resorption by osteoclasts. This is the mechanism of action of teriparatide.
What are the main adverse effects?
PTH originally has a function function of dilating blood vessels. You need to be careful of dizziness and orthostatic hypotension associated with vasodilation. Attention is also needed for temporary hypercalcemia associated with the bone resorption action of PTH. I will explain these in order.
Okay, the role of nutrition is also important. Diet high in calcium, 1,500 mg a day, and vitamin D is necessary. Calcium can be found in milk and dairy and in some fish such as sardines and salmon. Calcium supplements can also be taken if you're not getting enough calcium in your regular diet. As you get older, the absorption of all these calcium and minerals, right, is reduced, so maybe a supplementation is needed. Vitamin D helps your body absorb the calcium and can boost your vitamin, and you can boost your vitamin D by spending some time in the sun or through foods such as milk, fish, and liver. A multivitamin can also provide you the necessary amount of vitamin D for your body. Okay, talk about calcium, vitamin D, and vitamin K2. I personally take a supplement. I'm not endorsing any brand, that's why I put two brands here, right? You need to take calcium in this combination. Why? The combination of calcium, vitamin D, and vitamin K2 is a powerful synergistic trio for bone and cardiovascular health. Okay, you need the vitamin D3 to help absorb the calcium from the gut. So absorb the calcium from the gut, it goes to the bloodstream, right? But if it's too much calcium in the bloodstream, you can get calcified, isn't it? In your blood. So you need the vitamin K2, right, to send the calcium in the blood into the bones and to the teeth. Okay, how? It activates proteins like osteocalcin and matrix GLA that directs the calcium into the bones and teeth and away from the arteries. So your arteries don't get too calcified. This prevents calcification in soft tissues while strengthening the bone density. So if you choose a calcium supplement, it has to be this combination. Role of nutrition. Collagen is important because it's 70% of your bone mass. As we age, the body produces less collagen, and outwardly our skin begins to wrinkle and lose its youthful glow. Internally, we feel a weakening of the skeletal structure due to the degeneration of connective tissue, including our musculature. This can cause bones, joints, and blood vessel walls to weaken. Our blood vessel wall, our arteries, the wall also is collagen. And the body's ability to recover is also slowed down. To prevent degeneration of our bones and tissues, calcium supplementation alone is useless unless the support provided by the body's collagen is strong enough. Other factors: quit smoking and limiting alcohol can help. Smoking reduces estrogen levels and reduces the bone mass. Alcoholism can cause bone loss and make you likely to fall, isn't it? Because you're tipsy, right? To increase bone mass, you need to exercise. Walking and other weight-bearing exercise. Weight-bearing means like running, jogging, right? Cycling and swimming is non-weight-bearing. Especially good because they make your bones stronger. It's just like a challenge. Like you take weights, it will grow, right? Same thing. You challenge your bones. So the better plans in terms of nutrition, this decrease in bone making. So you make less bone, then the bone density decreases. So collagen supplementation is important. Deer antler velvet also has a lot of collagen and glucosamines and all that, right? Calcium AKG also have been shown to prevent osteoporosis and increase bone density. Decrease in calcium absorption with age, so we need vitamin D, calcium, and vitamin K2, soy isoflavones, right? Because decreased calcium absorption leads to low bone mineral. Decrease available mineral and protein, so slow bone healing and repair. So you can supplement with magnesium, which is also important for bone formation, vitamin K, zinc, selenium, and deer antler velvet. So victory in the battle. So live strong, be resilient, and faithful to God. Testament. Then you have a testimony of how you overcome your osteoporosis, right? Following these guidelines. Encouragement. The joy of the Lord is my strength. So this is Nehemiah 8:10. consistent exercise, especially walking, weight bearing, and balanced nutrition. So ultimately, trust God's plan while we live and act responsibly, right? So, okay, thank you. I hope that's been helpful.